So it's my pleasure to introduce both our speakers today. Henny Friedman has been a licensed registered nurse since 1974. She's also worked part-time as a labor and delivery nurse at Brookdale and is certified as a childbirth education instructor. She currently works at HASC in Borough Park and has worked there since 1988. Henny is very passionate about her job, but her greatest challenges are with the ongoing care for her husband, Moish, who was diagnosed with Lewy body dementia in 2008. She's his advocate and soulmate. She has recently published a book called The Unexpected Journey about her unexpected journey. Dr. Luca Giliberto, his approach to medicine and neurology has always been dual. Basic research as well as clinical practice. He completed medical school and his neurology residency in Italy, pursued research and a PhD in neuroscience, and then transferred to New York to work at Einstein Medical College and then again at the Feinstein Institute for Medical Research and trained as a neurologist at Northwell. He started his research on Alzheimer's disease during medical school and has pursued the difficult task of understanding its pathogenesis in order to find a cure since then. During his training and his career as a physician scientist, he worked on both amyloid and tau and expanded his investigations to more subtle aspects of the pathology, including cell cycle and tau processing. If anyone understood that, you don't belong in the session. In collaboration with the excellent team at Feinstein, along with other projects, he's researching the use of engineered antibodies to clear pathological tau from the brain. He practices neurology at Northwell and conducts clinical trials at Feinstein's Litwin-Zucker Center for Alzheimer's Disease and Memory Disorders. He feels that it is a privilege to work with basic science researchers and patients, and that they're both an invaluable asset to his approach to Alzheimer's disease. So Henny is going to speak first. Again, questions at the end, write them on the cards, and then Dr. Giliberto will speak. Okay, enjoy.
Good morning, everyone. It's my pleasure to meet you. It's not loud enough? Is this better? Okay. I think it needs to be a little higher. Oh, okay. Is that better? Oh, sit? Okay. Okay, fine. As mentioned before, the most important thing right now in my life is caring for my husband. And I just wanted to share with you some insights, things that I learned over the years. It's also interesting that it was mentioned that I work at HASC. HASC is a school for kids with special needs, and I'm dealing with children with various types of brain damage. And I find it quite ironic that I was given this challenge, which made me so much more sensitive to the needs of the parents of these kids. And so I just want to share a few things. First of all, I want to tell you that in the early 2000s, I felt that my husband had a certain amount of anxiety that I hadn't noticed before. And I blamed it on a lot of things. He worked very hard and slept very little. He was running an accounting practice, and he was also giving a Talmud class at 5:30 in the morning. So I thought it was that. It wasn't until 2006 that I was almost positive that something very, very serious was going on. And basically, I ran around from doctor to doctor for about 2 years, and I kept getting the same type of response. My husband was well-dressed. He seemed so intelligent, kind of like looking at me as the evil wife, like, what are you talking about? Nobody saw what I saw, and I feel very strongly that only a spouse can pick up the little small things that are so worrisome to us, because we understand what's normal for that person that we're living with. And I feel that you should trust yourself. If you feel that something is wrong, even if nobody else sees it, it's okay. Just keep going on and doing what your heart is telling you to do to get the right diagnosis. Why is it so important? I've heard from many people that there are certain doctors that say dementia's dementia, what's the big deal? So maybe it's Alzheimer's, or maybe it's Lewy body dementia. It's not going to make that much of a difference, but I found that to be very untrue, mostly because of reaction to medication. In certain types of dementia, people will respond better to different types of medication. And also the reverse, which is very important, is that certain medications will make things so much worse. What happened was one of the wrong diagnoses that was given to my husband was that I was told he has a seizure disorder. His brain scan on the EEG looked exactly like someone with a seizure disorder. So we started him on seizure medications, and every week I kept calling this doctor and saying, not only is he not getting better, he's worse. And it took a very, very long time for the doctor to pretty much get sick of me and say, okay, I believe you, just stop the meds, which I did. And you're supposed to wean a person off very, very slowly. As a nurse, I knew this, but apparently I didn't wean my husband off slowly enough. And it happens to be that even if you never had epilepsy or a seizure disorder and somebody put you on seizure medications and stopped them abruptly, you will have a seizure, even though you don't have that disorder. And that's exactly what happened to my husband. He had a terrible seizure on the city bus, and I got an emergency call to meet him at the hospital. Now, it really turned out to be a godsend, even though it was a week of hell and he ended up in an ICU unit. But because of that, because of ending up in Columbia Presbyterian, I was able to finally get a consultation with a memory specialist. And he said, within a week, I will give you clarity. I feel that something else I learned is today everything is very specialized. So going to a neurologist, you're going to want to ask yourself, what does this person deal with? Does this person deal with MS? Does this person deal with seizures? Each doctor is working with a certain category. And I was just seeking out a good neurologist. I never knew that I had to ask. So it's important. If you're worried about someone's memory or the possibility of dementia, I feel that it's very important to research finding a doctor who specializes in memory disorders, which is what brought me to Columbia Presbyterian at the time. I just want to share a few things with you, and I hope it might hit home with some of you. One of the most important things that you need to do, basically, is take care of yourself. I fortunately have a large support group, and those are my children. I have 8 married children, Kanahara. And my oldest son, Zevi, came over one day and he goes, Ma, I'm going to be the bad guy here. I need to tell you something. It's not that it's just me. I'm not the only one. I'm representing all your children. And I go, what is it, Zevi? He goes, Ma, we can't take it anymore. You've been crying for 3 months straight. We're losing our father, and now we're losing you. So I thought about it, and I realized, like, this is crazy. I need to pull my act together. I literally could not stop crying. And I said, I promise you that I'm going to go speak to someone, which I did. I promise you that I'm going to make things better. And I ended up over time taking medication to help me. Even though there's so much stigma, I hope that nowadays people understand that half the world is on something, and it's okay if you're feeling nervous and you want to take something and it makes you feel better and it helps you to cope, then I think it's a very positive thing. You also need to learn to ask for help. Dealing with dementia is not something that one person can do by themselves. It kind of takes an entire team. I feel that one of the most important things that you need to know is that you're going to need to get Medicaid. And it's complicated. And sometimes when you're feeling so overwhelmed, you push aside things like paperwork and taking care of those things. But if you can't do it yourself, which most of us can't, you pay someone a one-time fee to consult with someone who deals with Medicaid. There's a place in Brooklyn called Senior Care, and I'm sure there are many other places, where people specialize in helping you to get Medicaid. Many years ago, there was an issue. If you weren't 65, it was much more difficult. But several years ago, they passed a law that anybody dealing with a catastrophic illness will be eligible for Medicaid. And why do you need Medicaid? You need it because you need home health aides to help you. Initially, when my husband got sick, we rallied around him and we helped him. We also hired people, or people helped us voluntarily, or you paid privately, because it takes a little bit of time until you get the Medicaid. So don't put it off. You can't deal with something like this by yourself. It's something that requires 24/7 care. And if you want to do anything else and you're the only one caring for your spouse, it becomes next to impossible. I feel that sometimes it's very, very difficult. Before you get Medicaid, let's say you want to get someone just to come in and help you out with your husband for a few hours. And the difficulty is that your spouse or your parent or whoever it is very often feels that they don't need help. You know that they do, but they feel that they don't. You're trying to keep the dignity of the person, and it's really difficult. So sometimes you have to be a little ingenious, gather your thoughts together with the people that you're closest to and find a way to do it. What we did with my husband initially, before Medicaid, was I called a lot of people to find out if there's someone who has a lot of energy, a lot of patience, who will be respectful to my husband, to come and spend some time with him. He was still physically well. We wanted him to go to the gym, to get out of the house, to continue doing things and not just waiting at home for the wife. So we hired someone, and I called this guy up and I said, we have a lot of guests on Shabbos. Why don't you come for Shabbos lunch? My husband was used to the fact that we were always having company over, so I thought I would let him meet him. Maybe he's really going to like him, and it's going to be, I thought I was so smart. This is the best idea. He'll sit around the table, we'll get to know him. So I invite this guy over, and he's sitting at the table, we're having a nice time, and all of a sudden my husband looks up, he wags his finger at me, he goes, "Oh my God, I know exactly what you're doing." And I'm like, "What am I doing?" He said, "You invited this guy over here because you wanted him to take care of me, right? You want to hire him." I'm like, "Oh my God, what could I say?" My kids are holding their breath. I said, "You got me. You're just really smart. What could I tell you?" "Yes, I can't lie to you. I did. I thought you'd like him and maybe he could spend some time with you." He said, "Okay, I'll try it." He was very easygoing and good-natured about it. It doesn't always happen, I have to say. It can be one of the most challenging things that you need to do, is to getting the person that you love some help that's not you. So it's very important. It's very, very difficult to preserve a person's dignity. Even though we've come a long way over the last 20 or 30 years, I still find that most people do not want to talk about dementia, do not want to. It's like this big secret. It's okay to say that somebody has cancer. 5 left? Yep. Okay, it's okay to say that somebody has cancer, but it's not okay to say that somebody has dementia. But I found that despite the fact that my husband was so personable and adorable, at least I thought so, other people found him extremely annoying. And in order to preserve dignity, I found that it was very important to share his diagnosis. I remember having a handyman come to the house trying to fix something, and my husband must have asked him the same question like 15 times. "I'm used to it, this person is," and he's like, starts screaming at him. Like, this is not good. So the next time, because I work, my husband will be the one to open the door, the next time I handed a little index card to the guy, it said on it, "My husband's not well, please be patient with him," or I wrote, "My husband has dementia," I don't know what I wrote. But it was a completely different experience. And I know for sure that even if a person has certain impairments, they feel their emotions. They know when someone's impatient with them. They know when someone is treating them poorly. And he was very sensitive to this. And since my time is almost up, I just want to share one story for you. And that was that there was a time when my husband was very psychotic and nervous and not doing very, very well. We need to make changes with the medications, and my youngest child was engaged, and we were throwing a big engagement party. Most of the time we brought my husband to all these things, but this time we said, number 1, he doesn't know what's going on. Number 2, he's psychotic. Number 3, he's going to be overwhelmed. We're keeping him home, and that's it. We felt terrible about it, but we were sitting in the living room, and my husband and my son and some of my other children were sitting there. And my husband gets up, he walks towards my son. You have to understand, he did not know his kids' names for months. He calls him Yitzi. And yet he looks at his father, and oh my God, like he knows he knows it's me. He goes, Yitzi, he puts his arm around him, and he says, I just want to congratulate you. We were so sure that he had no idea. So always remember that we have no idea. We have no idea, despite what the person looks like, what is going on in his brain. So always be careful. Do not talk about the person in front of the person. Talk to him like he understands everything. Treat him with dignity. And please email me if you want. You can get the number from Achiezer. If you'd like to talk about anything specific, I'd be very, very happy to be in touch with any of you. Thank you so much.
Thank you, Henny. It's now my pleasure to introduce you to Dr. Giliberto. If you have a question and you want to pass them up, feel free. And there'll be questions and answers at the end. Okay?
All right. Do you hear me? Okay, excellent.
Not so
Mic is on. I'll be screaming. All right. First of all, thank you, the organizer. I'm so thrilled to be here. This is a great event. And Henny, thank you so much. You actually made my job much easier because this is exactly what I see every day, what I hear every day, and every single point she made is precise, is accurate, from the medication side effects to the fluctuations of cognition on and off, days good, days bad, and so forth, including the possibility of having seizures when you withdraw medications abruptly. So. I have a complex background, medical and basic science, and I'm trying here to put everything together so that you can have an understanding of how complex this is. In general, dementias, not only Alzheimer's disease. There's many, many types of dementias. Alzheimer's just happens to be the most frequent. One of the reasons being the population is aging, and the first #1 risk factor for Alzheimer's is age. So there you go. I had no conflicts of interest, unfortunately. So I want to start by presenting a few cases, and this, oh yes, a few clinical cases, 3 or 4, all Alzheimer's type dementia, which is different from Lewy body disease or Lewy body dementia. There is an Alzheimer's variant which has Lewy bodies, which is complicated, has features of Parkinson or Parkinsonism, and so it's some sort of transition and way in the middle between Alzheimer's and Parkinson, and it does behave like Lewy body disease. So these are all patients that I have seen in my practice. 97, 98-year-old woman who has come to me 4 or 5 years ago. This is actually one of my first patients when I started practicing North Shore back then. And apparently a person who was living by herself, driving her car, going around, doing her errands or chores, independent, playing tennis and so forth. A colleague of mine who's her neighbor told me, look, I don't want to see her because there's a conflict. I'm her neighbor. Let you see her. I see her. I dig into the history a little bit, and I find out that she had problems prior to seeing me, prior to just a few months ago. Maybe dating 1 or 2 years, so a little forgetfulness, the car being messed up a little bit more than it should, and so forth. So we ran a series of investigations, and I had to step over here, and the imaging of the brain is one of the most important things that we can, as neurologists, do. So look inside the brain, look what's going on. Is there atrophy? Is there vascular disease? Is there a tumor? Is there hydrocephalus? And I'll get to that. So we need to rule out that there are things that we can tackle, we can cure, we can treat, and so make it better. In this case, there was nothing such. What was happening, there was atrophy, meaning shrinking down of the brain volume, making these empty spaces inside the brain bigger, making the empty space around the brain bigger, and you're losing brain material, you're losing brain cells. So I diagnosed with Alzheimer's disease based on the clinical and the imaging presentation, nothing else going on. We ruled out other issues. And she had a hard time accepting the help of aides at home. but eventually we got there. It took a little tweaking. And now she's living at home. Some of the kids are taking care of her on medications. And again, took a little tweaking of medications to reach a stable situation, but she's doing fairly well. A very different case. 45-year-old, when she started having problems, she was a bank executive, and she couldn't get her work done. She was very confused. This is what we call a dysexecutive syndrome, meaning I don't know what to do with my work. I make mistakes due to different reasons. And she comes to me a few years later after she had to quit her job. And we do an MRI of the brain in a 48, 49-year-old woman. This is not good. This shows already atrophy. It's shrinking down. The brain is smaller than it should be, especially in this area, which is the temporal lobe. That's a lot of short-term memories right there. So in digging further, it turns out that the problems that she was having at work were not really dysexecutive, which would bring to a different diagnosis, but it was related to poor short-term memory and a lot of visual-spatial uncertainties. And we did this clock test, and she wasn't able to do it to complete. And so that's what I knew, well, this looks more like Alzheimer's disease. So we did another test, which is hopefully paid by insurances, but sometimes often not, a PET scan, a metabolic PET scan, and it did show a reduction of metabolism in certain areas, the parietal lobes and the temporal lobes, and this told me this is Alzheimer's. This is an early onset Alzheimer's disease. There's a possibility that this is genetically determined. Didn't want to pursue the genetic diagnosis. They didn't feel like it. There was no family history really. So we'll let it go, and she's doing fairly well on medication, very active, goes to the gym every day. Businessman, so kind of in the middle, 65, retired, doing well, forgetfulness, distractibility. Again, similar thing, we do, this is only a CAT scan, I don't have the MRI, so it's much more imprecise, but there is initial atrophy in the temporal lobes. And then we included him into a clinical trial at Feinstein. And in order to get into the clinical trial, you have to get the PET scan done for amyloid, which is one of the two bad proteins in Alzheimer's, and that turned out positive. So we started him on a medication on a clinical trial, and that is ongoing. And then finally, two very interesting cases. These are two twins, 81-year-old. I started seeing when they were 79. I don't know who is who, I don't remember, but as you saw from the first case, they both show significant atrophy in the brain shrinking down. The ventricles are big, and the spaces around the brain are big. So definitely something going on. One of the two has dementia, which I'll get to the definition in a minute, meaning she cannot live by herself anymore. She needs care 24/7. The other one is completely fine. She could go by her day. Now, they transfer into an assisted living for convenience sake, and one sister is taking care of the other at that place. We did an amyloid PET in both of them, and they're both positive. So these are two twins who have Alzheimer's disease. But one is doing fine, the other one has progressed into a dementia. So this tells you how complex this disease is. They're twins, they have the same genes, yet one has dementia, the other doesn't. And this is going on for 3 years already, so in the observation time, it's a decent amount of time. So there are many, many factors that can influence your progression towards dementia. It's not just your genes. Maybe there are some genes that we don't know of, and that makes a difference, but it's also how you live your life and how much cognitive reserve you have, which I'll talk to you about. So all of this to talk about cognitive functions. Cognitive functions, what are they? What does it mean? You're losing your ability to think, to remember, and to speak, and so forth. So number one thing is to pay attention. And you're all paying attention right now, but if there were people talking in the other room and music, it would be more difficult to do so. But paying attention, especially as you grow old, is fundamental to be able to remember and to really understand what the world is giving to you as an information. So cognitive function, if you pay attention, then you're able to do the other things. Understand and speak. You're able to read and memorize, and I'll ask you to please keep an eye on that, memorize these 3 words. Memorize more complex things, not just 3 words, but a whole paragraph. Can you take a second to read that? All right. Cognitive functions allow, and our brain allow us to understand space. This is an abstract figure, but you can make sense of it. There's a bunch of squares, triangles, and so you can probably also reproduce it. Read the time on a clock, solve problems, and do more complex actions, like working in a lab and nailing a nail. So cognition is at the center of a lot of functions. You have to have motivation, you need to be well and fit, you have to be alert and not sleeping or half asleep. Your mood has to be decent so that you can interact with the world and understand. And then you have to pay attention, make sure your hearing aids are working, and so forth. So it's complex. A lot of things come in to allow us to remember, think straight, and speak, and so forth. So does that mean that as we age, we're bound to lose all this? Really not. There are some things that persist, that are preserved as we age, and some things that are lost. How many of you remember any details of this story? So this is a projection of what the normal should be. In the 30s and 40s, you should remember 20 out of 50 details, but as you age, you remember far less. What is normal? Questionable. And why does that happen? Is it Alzheimer's? Well, not really. Not all the time. So there are some things that are stable and we keep as we age, and the things that decline. For example, your knowledge, your experience will stay there. You will remember how to perform a certain task that you've always done before. Your focused attention, like in this case, I'm speaking with you, there's nothing else distracting you, you're focusing, you can pay attention. But the multifocal attention, if somebody is speaking in the next room, there's loud music or noise and so forth, that's more difficult to maintain as we age as opposed to when we're young. Doing one thing at a time as opposed to doing multiple things at a time. When you're 25, you can do 50 things at a time. When you're 60, that changes. Resolving tricks, resolving problems, it's easier when you're young. You can still resolve the old tricks, the old problems, but learning how to resolve new problems may be a problem as you age. And so forth. And retrieving names and words. Somebody asked me earlier, is not being able to find a word a problem? Does that mean it's dementia? Not really. That's common to aging. There's many other factors that characterize dementia, but the speed of access to information is slower as we age. So that may be a problem if people can find words. So many factors interfere with our performances, with memory and so forth. Medications, number one, medications. I'll show you a list. And then a lot of health factors, cardiac, sleep apnea, a lot of things. Social issues, if one is very introverted and doesn't expose themselves to social activities, well, that is a problem. Medications. So there's so many medications that interfere with our cognitive abilities. So the first thing that I do when I see a patient is go through the list of medication in details, make sure there's no medications that can affect cognition in this patient. And some of them are very common, like a beta blocker or a calcium channel blocker used for blood pressure, or the medication used for bladder overactivity. Those will knock you down. Or antihistamines for allergies. Those will make you less performant. How to compensate? Well, pay attention. Make sure your medications are not doing you harm. Go to the doctor. Exercise, physical activity, very, very important. And in general, a good health. And make sure your hearing aids are working, because if you're not exposed to the environment, then you can't possibly remember or get things through. So Anybody remembers the three words that I told you earlier? All right, so these are pretty typical. We use them in the office all the time. Now, what I've described so far is really not dementia. Dementia, what it means is without the mind. So it's different from the physiological aging process. Dementia means you can't remember, even if I give you hints, even if I repeat it 10 times, even if you're concentrated and paying attention. And then you have some other problems. Your problem with speech, problem with handling objects, problem with reasoning and resolving problems, and knowing, for example, the names of your kids. It's a different situation from where you were 2 years prior. 2 years prior, you could work and function by yourself. Now you need help. That's probably dementia. And it's caused by a brain disease. There's a lot of brain diseases that can cause dementia. As I said, the main one is Alzheimer's, which is a degenerative disease, meaning the neuron starts to die, and we have not understood why yet. Some of them are relatively fixable, like if you have a nutritional deficit, B vitamins, for example, hypothyroidism, depression, if you have sleep apnea. So those things can fix the dementia presentation. But most of the time, the most frequent, again, is Alzheimer's disease, which we can't fix yet. Vascular dementia is very common, and oftentimes in this age group, vascular and Alzheimer's disease are mixed, are together. They go together hand in hand, and they actually worsen each other in terms of the brain pathology. Then you have frontotemporal lobe, Parkinsonian, including Lewy body, and normal pressure hydrocephalus, which is in an increase of the space, empty space in the brain, which can be fixed technically if it gets early enough. But we're not really good at identifying dementias. As Henny said earlier, oh my God, that's only 5 minutes. It's very we're not that good. It's very difficult. You got to find the right doctor that has the expertise and so forth. So I have not much time, so I'm going to skip through a lot of things. This is the first description of Alzheimer's disease. It turned out that this woman was a genetically determined Alzheimer's disease. She was young and she had family members affected, and the brain was kept in Germany for decades, and it was then sequenced, and they found a mutation, one of the familiar mutations for Alzheimer's disease. So that's a different case, but that's the very first case described. And you see, these are the drawings from Alois Alzheimer's. He drew tau tangles, there are amyloid plaques. So the two big proteins that make a mess in the brain and make the neurons die are tau and amyloid. Now, we don't know who comes first. It's still debated. As I said, number one risk factor is age. But so MCI, I wanted you to spend 1 minute on mild cognitive impairment. Mild cognitive impairment, as the word says, it's a situation where you have objective problems remembering or with other cognitive functions, but you're still independent. You're still going by your day, doing your chores, and so forth. And this is the precursors to Alzheimer's disease. This is the very, very important stage that we need to recognize as family members and doctors in order to be able to do something about the disease. So I will skip through a few of these. Mild cognitive impairment progresses to Alzheimer's disease about 10% a year. So 10% of the people who are diagnosed with the MCI progress to a dementia of Alzheimer's type. And there's several types. Alzheimer's is the following stage. When things get worse, when you can't be independent anymore, when you can't drive anymore, and so forth. Now, the figures here, and I want to stay on this slide for a second, they're terrifying, right? So about 5 to 6 million in the United States, about 60, 70 millions in the world, of course, is age-related. Women seem to be affected more than men, and there's probably hormonal and inflammation issues making that difference. Alzheimer's and dementias in general are more expensive than cardiovascular disease and cancer combined. And let me show you some figures here. By 2050, it is expected that the expenditure for Alzheimer's is going to reach $1 trillion. Three companies are worth 1 trillion: Apple, Microsoft, Amazon. That's it. There's 11 countries whose GDP is more than 1 trillion in the world. Cancer costs about 80-90 billions, just direct costs. Cardiovascular disease costs 200 billions. Currently, Alzheimer's costs 290 billions, but it will rise because of the aging population. This is a very important section. Elderly people are more and more aware of memory problems, so they actually want to be tested, but they're not. So we fail in that. And this is also very important because this was Henny's situation. Caregivers. The cost of Alzheimer's disease are not just direct costs of going to the hospital and getting medication and diagnostic procedure and so forth, but it's the lost productivity of the patient and the caregivers. So we don't have a lot of infrastructure in place to take care of them. Just a subdivision of the most frequent patients with Alzheimer's disease are in the 70 to 80s range. This is the projection. In 2050, we will have 14 million patients with Alzheimer's in the United States alone. Now there are about 5-6 million. For cancer, HIV, and other cardiovascular disease, for example, mortality has decreased over the last decade or so. For Alzheimer's, it has increased dramatically, 145%. This is why people with Alzheimer's disease go to the hospital, because they fall and other things. As I said, number one risk for Alzheimer's disease is age, but there are other risks. Some of them, we don't know exactly why, maybe hormonal. Down syndrome, patients with Down syndrome will develop Alzheimer's disease and pathology by the 30s. Some are unfamiliar Alzheimer's disease, like my second patient and like the very first patient from 100 years ago. But those are very rare cases, and usually there's a family history which is very clear, and every generation has one patient. That's not the sporadic Alzheimer's disease that we often see. And of course, your general health, cardiovascular health, if you're sedentary and so forth. Now, does education matter? There's something called cognitive reserve. If somebody is very stimulated, very smart, has had a very full and fulfilling life, they made a lot of connections in the brain, and they can hide the symptoms of Alzheimer's disease for a longer period of time. So they can go along well on this line and then decline a little faster. If somebody has not so many connections, they may start from a lower level of function and start declining earlier, but slower. So this is why sometimes you see patients that have been fine, like my first patient, 100 years old, is being completely fine until then, and then decline very fast. That's probably why. Once you have, of course, you have to rule out other issues. I will go very fast on this. We have numerous tools to assess dementia and cognitive problems. You come to the office, you get a lot of questions, I review your medications, I make you do all these weird tests. I'll ask you to repeat sentences, write a sentence, I'll ask you to count, I'll ask you to spell. This is what my overall assessment will look like. And I'll ask you to draw a clock, which in a normal person looks like this, but a person with Alzheimer's disease kind of degrades and becomes impossible to read. I'll ask you to do some weird tests with your hands and repeat signs, repeat actions. I'll ask you to solve a problem, and then I'll send you for an MRI or imaging of the brain, where I'll look for this area right here, which is the hippocampus, which is the part where the problem starts mostly in Alzheimer's disease. There are other tests that I can run, like a metabolic PET scan, which will show how the brain works functionally. There's an amyloid PET to look how much amyloid is in your brain, and currently we have a tau PET, looks at how much tau we have in your brain. We can use a spinal fluid to analyze proteins, although still questionable. We can use now blood tests to analyze some of these variants, but these are mostly for research purposes. And just in August, we were at the Alzheimer Association meeting in Los Angeles. There's a lot of promise about this, but they're not prime time yet. And this is a very frequent question that we get because the New York Times is going to publish this. You're going to see it and then call me and say, can I get that test done? Not yet. It's still being worked up. Now, what can we do? I'm sure some of you are familiar with the medications that we have available in the pharmacy, but unfortunately, they don't cure the disease. We have two big classes. One is the cholinesterase inhibitors, like the Aricept and so forth, and the other one is anti-toxic medications. They help a little bit, they make the performance a little better, but they don't solve the issue. Things will progress. We keep them at bay. And then we use other medication to control anxiety, agitation, psychosis, and so forth as well when they present. What are we doing in the research aspect? Well, it's kind of depressing because, as I was saying earlier to somebody in the audience, the things that I'm telling you right now, I could have told pretty much the same, I could have done pretty much the same talk 20 years ago. Okay? Things have not changed much. We have become very good at describing things because technology, but we haven't figured out why this disease happens really. So the trials currently are all failing, unfortunately. I mean, I wouldn't want that, but that's, you see all the scratch lines and so forth. Actually, this one is gone too. So you may remember what happened in April. Biogen fell down. Okay, so forget the Chinese trade war. Why are they failing? Well, because different problems. Maybe we don't have the right hypothesis, and we keep on doing the same thing over and over again. So we need to work more on that. And some of these have failed because we have produced very bad side effects. This is 20 years ago. We made people get an encephalitis and die. So really, there's no quick fix. There's a lot of speculation about supplements and so forth, but nothing has been proven to be effective to stop the disease. But we can manage a lot of the things, and we can still enroll patients in clinical trial because there are some clinical trials out there which are very encouraging. The one thing that has come over and over again to be beneficial is exercise. So being good cardiovascular health, including exercise, is good for Alzheimer's, for Parkinson's, for Lewy body disease, you name it. And being social, exercise with other people, exercise your brain. There's no specific activity that will be beneficial more than other, but anything that you like, you can put yourself to. This is what we need. In order to fix this, to make it better, and avoid the 1 trillion crisis in a few years, we need money for research, for policies, to get people to help, skills of people, nurses, social workers, people who teach you guys how to apply for Medicaid, people who will help you at home with your loved one that has this disease. That's what we need to go forward.
Job in the world.
Absolutely.
Okay, so the first question that we have is, we're going to take 5 minutes for questions. We want to let people stand up and shake. If I can trouble you to... Anyone else that has cards, please pass them up to the front. Regarding memory, is a gerontologist or a neurologist specializing in memory care a better person to deal with?
Well, the geriatrician will put you on the right track, will probably rule out a lot of the things that I've said very early. We need to make sure there's nothing else that is impairing your memory. So if your thyroid is off and so forth. And it also depends on the background of the geriatrician. Some geriatricians have a very good cognitive background as well. But I feel the neurologist at the end has the most tools available to figure things out.
Okay. Are there any new medications besides Namenda?
Namenda.
Yeah, thank you. And Aricept?
No, sorry.
Not yet.
Not yet.
And where is Feinstein?
Feinstein is right there, 300 Community Drive, 350 actually. And that's the phone number. You can ask of me or Erika, who is the administrator.
Okay, I think this question is more for Henny. What do you do for the parents who resist all help and feel they don't need the help? Where do we go from here? And then I'll give you my mother's phone number, because you can talk to her.
Just takes a lot of patience. You're going to have to try anything and everything that works. Maybe start off with people that the person is familiar with, friends of the family and relatives, and slowly work your way to strangers.
Okay, the use of aluminum, is that proven to be a factor in Alzheimer's, in development of
No,
Alzheimer's?
there was many studies in the 90s, but it's not been proven to be pathogenic, really. I wouldn't worry.
Aluminum.
Aluminum.
So
It
it's
was
been-
contained in a lot of antiacid medications. It probably still is, like the Tums and so forth. But there's no proof that that it has a major impact on pathology.
Okay, an individual with dementia refused taking any medications and help, what do you do?
It's tough. You have to.
An individual with dementia who refuses to take meds or help, what do you do?
So, you know, refusing to take medications or help, it may underlie a psychosis, it may underlie a character change and so forth. So, we can sneak in medications at a certain point and make it in a liquid form. It can be done, but you need to be very, very patient with the patients. You can't force them. You need to work with them somehow.
I want to thank our speakers. If you have more questions, write them on, write them on the index card and put your email on the index card. We will get responses back to you.